Okay, we're going to get started with the panel. A couple of the presentations were not in your packet from this panel, and they are, I think Lindsay tried to hand them out at the break, but if you didn't get them, they're out in the front as you leave. So some of the presentations from this panel will be out on the registration desk as you leave. Very eager to get right to what's going on in Missouri. So we'll start with our first speaker, is George Oestreich. And most of you know George. I always say he's the Missouri pharmacist extraordinaire. He is actually Deputy Director of the Missouri HealthNet service, HealthNet services, with the Missouri Department of Social Services. He's served as a pharmacist and a pharmacy administrator and an expert in numerous policy and organizational roles. He previously worked for the Missouri Pharmacy Association and was director of American Council of Pharmaceutical Education Program. He's been a guest lecturer in many venues and is a member of several professional organizations, including the American College of Clinical Pharmacy and the American Society of Consultant Pharmacists. So please welcome George Oestreich.
Thank you, Karen. Thanks for all of you being here. A nice rainy day, which will help keep you in a bit, but it is Friday, and I know Fridays are interesting times in the afternoon to try to get out a bit. I'd love to be able to tell you the whole definition of HealthNet. Actually, I think a lot of that book is yet to be written. What I'd like to share with you today in the brief period of time that I have is just some overview of where we've been transitioning the division over the last probably year and a half, and the focus that we've added to the division from a perspective of gaining information that we can use and get to our providers so that our providers have a better opportunity to work with us in providing the care for the participants. I also like to share as I go through just a little vignette of what Medicaid looks like from a perspective of those that are most in need of health care. And let me probably use, there we go. One of the reasons that we embarked on the mission several years ago was the fact that Missouri simply can't sustain the growth in Medicaid that we've experienced over the last really 5 to 10 years. And you can see from the graphic here very briefly that the upper level are our disabled population, who comprise a very large part of the expenditures associated with the division expenditures in our fee-for-service program. And this is clearly unsustainable as we go into the first 25 years of this millennium. The other part that I like to bring out to kind of give you a bit of background on Medicaid is what a Medicaid patient looks like, what the disease prevalence within Medicaid looks like for the patients that we're most concerned about and who contribute most greatly to the expenditures that I outlined there. And I would point out to you just if you look at our benchmark numbers, again, I apologize these slides weren't in your packet, but they'll be available to you afterwards if you have an interest in acquiring them. If you look at our asthma line, the second line down, the benchmark is a benchmark for private sector population, and the actual is actual for fee-for-service Medicaid alone, and then the relative difference is an expression of the ratio there. So if you look at things like asthma and look at particularly behavioral health issues, in bipolar, we're at 588% of the benchmark private sector. Chronic heart failure, 167%. Depression, 131%. Diabetes, 56%. Interestingly enough, if you drop down to hypertension, we see we're at a negative. And I always like to point out the reason is that the intro diagnosis and the presenting diagnosis for the predominant number of Medicaid folks is not a simple diagnosis such as hypertension. That would be just an integrated piece of the whole clinical picture for those individuals, and certainly not a part of that. It represents the complexity of the patient population, if you will, and that's the essence of that comment. We've been moving in a changing philosophy within the division for really a couple of years now. Social service role primarily in prior to 2000 was a passive claims payment agent, functioned as an enrollment and a safety net provider. Only within the last 3 or 4 years have we really been trying to accentuate the care management programs, our electronic health record engagement into the provider community and bringing those pieces of data available to the providers, and then identifying standards and references to try to resolve the treatment gaps that we see within our patients. We are now emphasizing on maintaining and improving the health status. We feel like if we're doing the right things for the individual at the early point, that what we can do is to bend that trend. We're certainly not going to bend the trend of expenditures. We're certainly not going to erode the trend or go to a negative trend. Certainly with the population that I've just sort of overviewed for you, that's not really going to be an opportunity. We can perhaps retard the progression of the disease. We can perhaps educate the patient to be more empowered in dealing with the disease and partnering with us in a collaborative fashion, but it's very clear that we're not going to be able to turn back the clock for those individuals who are already chronically ill, nor are we going to be able to prevent totally the progression of disease that comes from some of the issues that are associated with the population that we're working with from an iatrogenic perspective, more from a chronic perspective, and from a genetic perspective. It is a consumer-focused and driven by individual health needs. The basic tenets, I usually like to drop down to the very last one most quickly. The rest of them are fairly straight up in the utilization of the technology and the medical evidence that's available to us. But the second one's very important to us as well, to make all of these opportunities as transparent to our provider population and our participant population as possible, so that we're not really impeding care and not really adding additional cost to the system from certification processes and pre-certification processes or prior authorization processes that would be cumbersome and actually reduce access. In reporting, we're constantly finding the opportunity to have comparative data from our system to other state systems, to other provider network systems, trying to see what's been happening right and what's been happening wrong, and how can we integrate some of the right things into the program as we transform the system. Reviewing certainly the quality assurance and program policy, but very importantly, as I alluded to, not punishing the many for the sins of a few. Don't put artificial roadblocks in the way of providing care when we can at all avoid that, and to the extent that we can avoid it. And moving away from paying for just things by paying just bills as they come in, and trying to make a determination on the front end of the best opportunity for the patients to receive the most targeted care based on their individual needs and diseases. Again, designing these programs so that the target service intensity is consistent with the patient's medical needs. This is sort of an aggregating slide just showing you the current system pre-2000 to where we've been trying to go over the last half a decade, and very directly where we're trying to go with Mo HealthNet. The issue up until Mo HealthNet, we realized that we had about 80% of our expenditures within 20% of our population, and we knew to try to bend that trend, we needed to target our few resources to the sickest individuals, the individuals that had the most to gain and lose by the quality of care that we would advance toward them and pay for on their behalf. So that's where we started with the chronic care program. Dr. Barrow will have an opportunity to share a few of the outcomes for that, and I would just share with you a precursor to some of those outcomes with one of our current disease management programs. A very good point was made in the last presentation of one trying not to just silo targeted resources, but to try to see how those silos fit as we target resources to a patient who is not uniquely ill from one disease, but comorbid disease processes going on within each of our patients more often than not. So we actually have moved from the top of these inverted pyramids with Mo HealthNet to the very bottom, moving quickly down where we're taking the opportunity to target the health home with the individual, the recognition of early disease with the individual, and trying to develop the outreach and empowerment of the individuals. So it was a process that was in place, but one that has been accentuated a great deal by the legislation. What I mentioned earlier is our opportunity to use data and to use that data in an integrated repository. That's been the essence of the programs that we brought forward so far, is trying to jury using business rules to the opportunity to judge whether it made sense for a particular treatment paradigm to go forward, and try to make sure that we're on board with the providers in the need, and that they're on board with the information to make the appropriate determinations that they need to. all the time realizing that those decisions need to rest with the providers, but we are responsible to deliver information to them that helps them to the best of our ability to know all of the data available around that patient's history and claims-driven data that we have available to share, and do that as a near real-time basis as we can. The self-service model is what we've been embarking on over the last, since a year ago, July, with the rollout of our electronic health record and the participation of that in the field of provider enrollment and provider and the integrity of the providers in the pre-certification process. But also the outcomes in the center section of the reports and the clinical scoring for the individuals, the risk assessments, the treatment suggestions and the trending, moving that to a portal that's available first to our provider network and then to the payer network, us, and then ultimately later this year we'll be making a portal available to our recipient participant base so that we can again rules engine out information to them directly, as well as to empower them to achieve information around the treatment guidelines that we're trying to promote within the delivery of services to them. So just a quick overview on that perspective. Now the main topic today was where we're going from here forward and the complete integration of some of the issues associated with our rollout in imaging and the pre-cert of the medical equipment that we're in phase 3 on, the integration of the new delivery models with the Medicaid reform legislation. Additional services were added with Senate Bill 577 for optometric and dental, although those have not been funded to date, but we're in the process of being ready to implement those if funding does occur. Our statewide patient health record is an initiative that will be reaching out for proposals later this fiscal year. The premium offset program is very actively moving forward. The long-term care insurance integration is again part of 577 that's well along in its process of integration. And most recently was a transformation grant that we received from the Centers for Medicaid and Medicare to integrate our current electronic tools into the rollout of home and community-based services and waiver services, as well as the evaluation associated with those. 577 as an overview did remove the sunset from Missouri Medicaid, so we knew full well that was coming, but didn't know in what form. Changed our name, so we're now the Missouri HealthNet division, and I think that more speaks to the mission that's been really preferred for us, as well as what we just talked about, moving from a payer to actually a collaborator in the care of our individuals. Extending coverage to the Ticket to Work folks and the sheltered workshop participants and our disabled workers with higher incomes. Changes in the affordability of SCHP. Of course, that's, as we well know, is a much broader topic than what we're even about today, and we'll need a little more clarification from a federal level there, but we certainly we're moving toward broadening the opportunity for individuals there. And in Insure Missouri, that certainly tags into the parents for the SCHP patients as well. So there is a tie back to the overall Mo HealthNet vision. Establishing a pay-for-performance program, that's a part of our chronic care improvement program as we're here today, and we hope that as the governor appoints the oversight committee and the committee associated with P4P issues, that we will have gained some knowledge base in the implementation of P4P in our chronic care program. We're looking at it from a perspective, for those of you that are interested in P4P, looking at it from a practice-specific parameters, basically, not trying to compare a patient's population that may be sicker than your population if you're a provider, but letting you compare where you were with your provider networked panel to where you are at an outcome basis, so that you're competing basically against yourself and competing for the opportunity for the outcomes for the patient population within your practice. Also, we realize with the metrics that we're developing that you do not practice in a vacuum, and it takes empowerment and coordination from a perspective of the patient to work with you before those goals can be achieved, and making certain that we're not setting up parameters of which you have less control over to put you in in a perspective of comparison. And also, most importantly, that you can do nothing but win there, that there's not an opportunity for your total reimbursement to be based on the P4P model, but rather we know full well that your reimbursement to our primary care providers is far below what it should be, and that's a freestanding separate issue, not directly tied to the P4P initiative. And again, I mentioned the coverage on optometric and dental. We've moved to the provider reimbursement closer to Medicare, as I alluded to just a moment ago. We are at 55% of Medicare now. We know full well that over the next 3 or 4 years we need to move much more closely to that in order to gain access to the providers that are participant-based needs. Establishing the prior authorization or pre-certification of durable medical equipment was in 577 and really an extension of what we had begun. And we're using that in a pre-cert program through the cyber access so that it can be more real-time with the patient population and not take 4 to sometimes 6 weeks for approval, but be in the matter of days and perhaps at the very end hours. Moving to the premium offset program, providing a standardized health insurance product, and then subject to the oversight committee that we'll talk about just in a moment. Establishing the guidelines for data interchange and exchange with other third parties. Even as recently as yesterday, we were working toward the discussion with our MCO partners of finding a way to integrate greater numbers of encounter data with more validated data fields on an HL7 basis into an interoperable venue with our current tools. As you know, that 577 did expand the women's health program, basically in an eligibility access basis as opposed to the services provider. The complete details of that are in the cited section. We'll be promulgating rules for telehealth to try to make sure that we do, A, protect the network that we have established and to broaden that network and to make certain that there is reimbursement at both ends of the network using a spoke hub opportunity so that we can have sustainability of that program as we move forward. We're very close to filing the rules associated with that program. Will happen before the end of the calendar year. The long-term care partnership, providing the mechanisms to fund private long-term care insurance and HealthNet through the HealthNet program, allowing a future HealthNet coverage without exhausting the resources of the individual. So we can hold the folks into their home longer, and when they need to move into a long-term care setting, if in fact that ever occurs, that the resources will be intact at that move, and they'll not be impoverished before that move and the burden be yet another added burden to the state. Provides for specific health care studies. I think this is the most exciting part of HealthNet, is the opportunity to actually look at all the access points that we have in our system and to look at what really is making the system work well, what is really improving outcomes, what is really valid for us to increase payment for and to encourage. And we certainly are pleased to partner with the University of Missouri in the prospect of judging some of the outcomes and the relative roles of those in our process. It establishes further healthcare improvement plans. Basically, this is a euphemism for an access issue. The risk-bearing coordinated care model is the MCO model. The Administrative Services Organization would look very much like the Chronic Care Improvement Program that we have with our ACS and APS partners, of which Dr. Barrow will have an opportunity to give you some oversight from. And the Coordinated Fee-for-Service Plan is really where we're at now, but bringing that up, as Emerald would say, to a new level. And we're trying to get a little bit more spice in that, if you will, from a response point. Mandating the healthcare home, that's really a challenge in and of itself, and it's hard to sort of bring that to light to those who are outside of the system. It's much more difficult than just saying you need to have a healthcare home. Defining a healthcare home really goes to the point of, is it a primary care provider? Is it a community mental health center? Is it an RHC? Is it one individual? And I think where we're landing on that, and you know, I have some level of resistance to doing that by rule because of the flexibility within that needs to be within the program and deciding what that in fact needs to be. But the healthcare home is really contingent upon the needs of the patient, and it needs to be customized to that patient, and it's not static. So it needs to be a little more fluid, but in the same respect, we need to be working in concert with our provider partners so that we enfranchise them to the process as well. And then, of course, this is all subject to our oversight committee, of which is yet to be appointed, but I understand imminent. So we have here outlined the 18 members of the oversight committee, and we're anxiously awaiting their appointment, and then we'll engage them at the very earliest process. And I'll not spend any time directly on that, but we can do that in the Q&A if you want. It also establishes the P4P committee and then a single point of entry committee, which is a subset, interestingly enough, 3 persons larger than the oversight committee itself. So that'll be an administrative opportunity for a little bit of struggle as well. The Joint Committee on HealthNet is an internal committee of the General Assembly, 10 members of that body, to study a 5-year rolling budget for us and to make recommendations back to their home body and certainly to the administration. And then I alluded to the Professional Services Payment Committee, which is again another 18 folks that will develop and oversee the P4P program and reestablish that for a statewide opportunity as opposed to the opportunity for just internal to the agency. And it includes predominantly the number of folks. The sort of segue slide that I'd like to share with you is some of the outcomes on the disease management program from the 02-08 range. And it shows that although the N for this was about 700 people, we do see some things here that we like a lot. The control to change group and hospitalizations, we do see a decrease there, and we see that outward into the out years even greater. Our ER visits are down some, drug-related problems are down some, and we're seeing the overall savings also increase as a percentage of the overall program expenditures on a per member per month basis. So we were seeing the right things in that little bitty program, and we hope we can transform the newer, larger program into achieving some of those same sorts of ideas. Just to give you a bit of the rollout, the current managed Medicare, Medicaid care counties gives you about an idea of where we are now, and I'll just go through these very quickly as we roll out the chronic care improvement program that was in the corridor of the managed care environment as well in our fee-for-service population. We then went to the northeast corner, down to the southeast corner, which we're at now. We have about 57,000 of our 140,000 eligibles of our total 550,000. Then we'll move over to the southwest and then into the northwest as the latter part. And I would suggest to you that's probably the logic we will use in rolling out HealthNet as we move forward. And again, the difference in that population of the relative disease prevalence within the population. And then finally, we'll add the MCO contiguous counties associated with that individual extra 21 counties, if you will, and that's targeted to occur January 1. I think I'll leave off there with just that smattering of oversight and overview, rather, and then be back to you with questions that you have that are specific to the opportunity.
George, I know you think you're finished, but Dr. Barra had an emergency and had to leave, and so after Joe's presentation, I may ask you just to say a little bit more word about the CCIP program. Could you do that? Yeah. Or maybe just take it in questions. We'll decide.
No, I think we can use some of the slides.
Okay. Our next speaker is Joseph Purley, and most of you know Joe. He's the CEO of the Missouri Primary Care Association, where his responsibilities include corporate affairs and working with state and federal legislators, policymakers, and other officials to develop policy and issue statements. He's also the CEO of the Oral Health Network of Missouri and is responsible for corporate affairs as well as developing and advocating for policies to increase oral health care access and reduce oral health disease. In a previous life, he worked for Senator Christopher Bond, where he was the senator's chief advisor on health, Medicaid, Medicare, children, elderly, social service, and veterans issues. So welcome, Joe.
Thank you, Dr. Edison, and hello, everyone. I appreciate the opportunity to be here. I always enjoy speaking late on a Friday afternoon. especially before an event sponsored by the University of Missouri, because I get the opportunity to say, "Go Jayhawks." So I was asked to talk a little bit about FQHCs, or community health centers, and I'll use that interchangeably, how we relate to Medicaid, and some priorities and principles that we established early on regarding Medicaid reform, and to give some thoughts about the new HealthNet legislation, where things stand today, and what opportunities we think it presents. And I'll touch a little bit upon covering the uninsured. So just really quick, and this is 2006 data. 07 data is a little bit different, but today there's 19 health centers. We have about 110 locations, serving about 310,000 Missourians through about 1.1 million annual visits. We did an analysis last year and realized that our patients come from 650 communities or towns or cities across the state. So we have many patients that in some instances travel large distances to obtain health care, whether it's medical or dental care. Our total patients have increased pretty significantly by about 37% over the past 5 years, and we've really put an emphasis on access to dental care. And I think it's becoming more and more well known that dental care is just as important as medical care, mental health services, etc. So we've really placed an emphasis on that and have increased our encounters significantly. We served about 126,000 uninsured patients, which is a 52% increase over 5 years. And today, if you look at a health center, on average, about 40% of a health center's patients are uninsured. They have no source of insurance, and they do pay on a sliding fee scale. So they come in, we do an analysis of what their income is, and charge them on a sliding fee basis. In 2006, we saw about 115,000 Medicaid patients, which has increased about 48% over 5 years. But in the next slide, I'll note that obviously we saw a reduction in the number of our Medicaid patients by about 6.5% from 05 to 06. And that had to do with some of the changes that were made at the state level in regards to Medicaid eligibility. And obviously that has an impact on the patients. It has an impact on the health centers financially, who are trying to provide comprehensive care. And nearly a quarter of all Missourians living in poverty today are served by a community health center. And one final statistic is about 90% of our patients live below 200% of poverty. And this is the chart that I was referencing, and it's not a chart that I like to look at, but you can see our Medicaid users declining and our uninsured continuing to climb. But we anticipate that changing early next year. Just really quick, some things that make a health center unique. We have to serve an MUA, a medically underserved area, which means that there's a high poverty rate in the community, there's a high elderly rate, there's a high infant mortality rate, and generally there's a lack of providers that serve the underserved in that community. And oftentimes I get asked, why in the world do you have a community health center in Columbia, Missouri, or Springfield, Missouri? And I'll tell you right now, our health center in Springfield, Missouri is the fastest growing health center in the state. And in Columbia, Missouri, that health center serves 10,000 patients. We're there to serve the underserved, and that's what we're trying to do. Our health centers have to be independent, nonprofits, and we must provide a comprehensive array of primary care services, inclusive of medical, dental, mental health, and pharmacy. I'm going to slip this or go on past this. So Medicaid reform. Early on, we established some principles heading into Medicaid reform, and we actually worked with the Rural Health Association to find some linkages between our two organizations. And this is what we focused on. Medicaid reform should promote healthy lifestyles and expand access to preventive care and primary care. We should assure adequate provider participation and consider raising provider reimbursement rates to appropriate levels. Assure that every Missourian living in poverty has access to affordable health coverage. Provide additional grant funding to entities that disproportionately serve uninsured individuals, with the whole effort of seeking a reduction in inappropriate ER usage, preventable hospitalizations, and duplication of services. And we really need to do a better job of coordinating our services at providers at the local level. And that's in integrating our services. For instance, in the same community, you may have an FQHC and you may have a community mental health center. We as providers need to do a better job communicating and working together to integrate our services to make sure that our patients, which are common patients, have access to appropriate care at the right time. Of course, rooting out fraud and abuse was one of our principles, and I just touched upon promoting linkages between primary, secondary, and tertiary and long-term care services. And finally, including a Medicaid 101 provider and patient education. To provide patients with the tools that are necessary for them to be good patients, which in some instances maybe means showing up for their appointments. The overall arching goals we really looked at was transitioning Medicaid from merely, as George touched upon, a claims payment program to a public health improvement program. Traditionally, Medicaid, the only thing Medicaid has done is pay claims. Provider sees a patient, provider submits the claim, Medicaid pays the claim. We really need to do, and we are, I believe, doing a better job in getting patients and providers actively involved in managing health care and to improve the lives of our patients. Today, it may be too early to tell what the results of the new HealthNet legislation are, and it is HealthNet, I believe, not Missouri HealthNet. I think somebody else, another company or something, claimed Missouri HealthNet. Am I right, George?
There's some discussion about that. Yeah.
Still some discussion about that. And finally, we do believe that some of the changes made within the HealthNet legislation place more emphasis on the importance of early prevention, primary and secondary prevention, primary care, and chronic disease management. And these ultimately are what we think we should see from the Medicaid reform. Lower medical costs due to effective chronic disease management, the prevention of unnecessary hospitalizations, prevention of the need for more specialty care, and to reduce costly ER visits. But ultimately, in our view, the ultimate goal of Medicaid reform should be to improve health outcomes. We can do everything else, but unless we improve the health of our patients, and unless we got to get our patients engaged to improve their own health, and that's what we're all trying to do. We do believe that there are other issues that still need to be addressed. We think that Medicaid reform will fail unless these issues are addressed. And this issue is becoming more pronounced every day. The state, local communities, the federal government, we need to work together to stem the erosion in primary care capacity. And we have significant workforce issues facing the state of Missouri. We have a shortage and maldistribution of primary care physicians, nurses, dentists, dental hygienists, pharmacists. You can go on down. And unless we as a state begin to address these issues today, this problem is only going to become worse. Finally, covering the uninsured is extremely important. And yes, the HealthNet legislation did have some pieces within it to address the uninsured. And as a result, we all saw Governor Blunt a few weeks ago announce a new initiative called Insure Missouri, which this HealthNet legislation gave him the ability to do that. And why is this important? For health centers, it's important because we disproportionately serve the uninsured. As a provider, 40% of our patients are uninsured. So we have a significant interest. But it's from a financial perspective, yes, there's that interest. We would love for all of our patients to have some form of insurance. But we do believe that if the individual has access to health insurance, that individual will have better health outcomes. If the parents of children on Medicaid have access to health insurance, we believe that their children are more likely to have access to health care and more likely to seek early preventive and primary care services. But just within a health center, it's not uncommon for a new uninsured patient to come to our health centers to present with chest pain, abdominal pain, a mouth full decay, and severe depression. our patients don't come to us with just a medical issue. They often have a multitude of complex issues. And we do think that having access to affordable health insurance will, again, improve their lives and their health. So one answer, and I know Daniel Landon with the Missouri Hospital Association will touch on it next, is Insure Missouri. And I don't want to say that's the only answer. There are obviously other solutions out there, but this is one issue that has been presented and is on the table, and we think it's a good thing. This initiative will cover working parents of children who are on Medicaid. And we think it's a good thing because, one, it provides a comprehensive package of services, although it is lacking dental, but we hope that some of the managed care plans or health plans that bid on it will include dental in their package. But it's a public-private solution to a complex issue, and we think it's a meaningful compromise on how to expand coverage. But most importantly, we believe that the Insure Missouri initiative is sensitive to the individual and the family's income status. Those families at 100% of poverty and below will not have to pay a premium. They will have nominal co-pays, much like what there are in the current Medicaid program. So we think that's the key, that it is sensitive to their family income. I think I'll end there. I'll turn it over to Daniel, and we'll answer questions at the end. So thank you.
Thanks, Joe. Our next speaker is Daniel Landon. He's the Senior Vice President for Government Relations for the Missouri Hospital Association. He joined MHA in 1993. Seems like yesterday, didn't it? His responsibilities include managing the association's federal and state advocacy functions and performance measure programs. Before joining MHA, he worked for House research staff of the Missouri House of Representatives for nearly 10 years. And that staff, as you know, provides nonpartisan research, policy analysis, bill drafting services to the House of Representatives, its committees, and individual legislators. I've asked Dan to come and talk a little bit about the new Insure Missouri program, and so we welcome you.
Well, thank you very much. I am glad to come here and talk about the Insure Missouri program, but before I do, since the topic of this seminar is on HealthNet, I do think that I want to express our members' appreciation for the work that George is doing in implementing the HealthNet program, and to say the focus on disease management is absolutely the right way to go. That's not necessarily a product of HealthNet, as has been mentioned. It was going on before then. Will probably continue to go on, but it is the right thing for the patients. It's the right thing for the system. With that, let me see if I can work this. Looks like I've got.
This is not your presentation, is it? Sorry.
There we go. Okay. I would like to walk briefly through a description of what's going on for the Insure Missouri program, again unveiled by the governor last month. A lot of people have expressed a number of questions about that. Basically, this is a program that would offer expanded coverage to the uninsured. It would be implemented as proposed in 3 different stages. The first stage would be implemented very soon. They're working on this pretty feverishly right now. And it would offer coverage to uninsured parents and or custodial caregivers with incomes up to 100% of the federal poverty level. That's about $20,000 a year for a family of 4. There is money in the current budget to fund this, and so it could begin coverage as early as March of '08. Stage 2, second stage, would go into effect, if things go well, in July at the beginning of fiscal year 2009. It would offer coverage and somewhat expand upon the group that was covered earlier. It would offer coverage to uninsured parents and caregivers with incomes between 100% of poverty and 185% of poverty. Also at the same time, it would offer coverage of uninsured childless adults with incomes up to 185% of poverty. If the General Assembly and CMS offer their approval for the program, again, it could begin as early as the beginning of fiscal year '09 and July '08. In this population, there would be capped cost-sharing requirements. Joe had mentioned that for the first stage, it'd really be nominal co-payments, very comparable to what is offered under the Medicaid program for the below-poverty population. For this population, basically the cost-sharing would be capped at 5% of their income. The third stage is a little bit longer project. It would begin in 2009 and would focus on covering uninsured workers in firms that employ 25 or fewer employees. It would involve the payment of premiums by both the employee and the employers. And as is now being discussed, but it looks like a way to structure this might not be to have the public subsidy of this program be offered in terms essentially of a subsidy of a percent of premium, but instead to use the money to offer coverage of reinsurance that would reduce the cost of employer-sponsored coverage. For example, the state could somehow provide reinsurance for this population that would say pay the claims that exceed $20,000 on a particular patient. Paying those claims through reinsurance would reduce the employer's cost of buying coverage for the rest of those claims and again make it more affordable. That has some advantages toward just paying directly toward the cost of the original policy. I hope you can read this. This is a kind of an overview of the enrollment estimates. Phase 1, basically, we would estimate would cover about 54,000 people, and that would continue throughout the 5-year snapshot we're giving of enrollment projections here. Phase 2 would be gradually growing over time, starting in fiscal 09 at about 50,000 people and growing to just over 100,000, 107,000. And finally, Phase 3, the small employer portion, we would project to start out at about 28,000 and basically be static throughout the program. Altogether, this program, if implemented as projected, would cover about 190,000 people by 2012. This is sort of similar data, just if you're a visual person, it gives you the idea in graphic form of how enrollment grows over time through 2012. The benefit package. Because of CMS requirements, the benefit package will have to be approved by them, and largely there's a standard that it must include covered benefits generally available to healthcare consumers in the healthcare marketplace. How that plays out is basically a list of services that would be covered here, prescription drugs, hospital services, physician services, and the like. It would include inpatient and outpatient mental health. As Joe pointed out, it would not cover dental in this iteration, but that's presumably something that could be offered by the plans. It would not cover maternity, with the idea that obstetrical services are already covered for women up to 185% of poverty. The idea is those services could be covered as a wraparound by Medicaid and would not be covered under this policy. Funding sources, where the rubber hits the road. As proposed, the state would use about $47 million of its general revenue fund by the time this program gets rolling in fiscal year 2010. The general revenue obligation for the program would be capped at that level. So it would grow to there and then stop. Other funds would come from the FRA, which stands for the Federal Reimbursement Allowance Program. If you're not familiar with that, that is a provider tax that's paid by hospitals to the state and used to generate federal HealthNet match. I guess at the federal level it's still Medicaid. I'm still used to saying federal Medicaid match. So in that first full fiscal year, it would generate about $71 million in FRA funds. Those funds do grow, and by 2012, we would be allocating about $189 million in those hospital provider tax funds. Also, there would be a shift in what hospitals would be receiving in terms of disproportionate share hospital payments. Those are payments that are made to hospitals to recoup part of their cost of the uninsured. All of the state's share of funding those costs of the uninsured payments is funded by our FRA. There is no general revenue in there, so it's really all coming from the same pot. But the idea here is that hospitals would have fewer uninsured patients coming through their doors if the Insure Missouri program is successful in offering coverage to 189,000 people. Therefore, we won't need those disproportionate share hospital payments, and it would be a prudent investment on our part to reinvest them and buy the coverage up front. We have long had the presumption and the assertion that it's a lot better to buy people coverage up front and not wait until after they're uninsured to try to recoup some part of their care. That is not only administratively inefficient, it's bad for the patient. You want people to have coverage and be able to get in and see a doctor either in his office or in an FQHC so that they avoid having their conditions become serious. Estimated costs, again, this is somewhat the same numbers. These numbers do include actually the projected employer premium costs and the employee premium costs that would be recovered over the program. All told, when you're adding everything up, by 2012, this would be a program that would involve about $890 million. Now, all the implementation of this will require some federal authorization from CMS. The division is now preparing state plan amendments and waivers to cover the populations I've mentioned. Largely, the state plan amendments will be all that are needed to cover this first phase of eligibility for parents and custodial caregivers, because they're a population that MoHealthNet is already authorized to cover. They don't need any special permission to cover a new type of enrollee. It's just a matter of changing the eligibility standards. In contrast, waivers will be needed for childless adults and for the Stage 3 premium assistance programs for those employers in firms of 25 or fewer. Next steps, an RFP has already been issued and to serve the Stage 1 population. It's under review now by the health plans, and I guess they've recently had a meeting to get answers to some of the questions that are raised by that RFP. The state must file and CMS must approve the state plan amendments and the waivers that are necessary. That will not necessarily be a quick process in the case of the waivers. We hope that it will be a quick process in the terms of the state plan amendments. State legislators will need to appropriate money to fund this in the fiscal year that begins in July of next year and beyond. And they also may need to implement some statutory changes in order to flesh out how the remaining portions of this program are going to be implemented. Again, the first stage basically is being implemented under the authorization of an appropriation that was included in this year's MoHealthNet budget. And finally, and not least of all, we need to get out and find out where these people are and to sign them up and tell them they're eligible. There's certainly precedent for this. When the original SCHP program became expanded in 1997, hospitals were very involved in working with the state in trying to find out where people were and how we could sign those people up. And so I would anticipate doing something in the future on this as well. Many people, including ourselves, are concerned about controlling costs in a program. The last thing we need is an out-of-control expenditure program for MoHealthNet. There are several different ways that Insure Missouri can cap its costs. One is under a federal waiver, you can clearly cap the number of people who are going to participate. Whereas in a plan amendment, basically you're saying people who meet these criteria, if they meet them, they will have to be covered. But in a waiver, you can say we will cover X number of people, and when you get to X plus 1, it is possible for the state to say, I'm sorry, you're not eligible. Generally, wage earners of the type we're talking about here, and these are the people who would have been covered prior to the 2005 cuts, many of them, they're pretty cheap. Not as cheap as kids, but they're pretty cheap. In 2004, this population was only costing about $227 per member per month. And finally, as is always the case, income eligibility would be controlled by the appropriations process, and so the General Assembly retains the authority to authorize the income levels. Eligibility determination would go through the Missouri Division of Family Support, as would currently be the case. It's been projected, and I think is going to be happening under some work that's undergoing now, that they'll be in a process where people can enroll electronically. As providers, we're certainly interested in making sure that if that electronic enrollment is available, we could have it in our hospitals and sign people up when they're there to expedite, again, getting as many people enrolled in the program as would be eligible. Finally, it will be implemented in various regions. This is a color-coded map of the Insure Missouri regions just to get a sense of where things are coming from. There will be RFP requests out for Stage 1 in these regions. It is probably likely that there will not be a one-size-fits-all implementation of this program. It will probably look somewhat different in southwest Missouri than it does in the I-70 corridor, where there is already an existing infrastructure for managed care. And with that, there is quite a bit more information available about this program at the website I've listed. And I would be happy to turn it over back to Dr. Edison, and we'd respond to questions.
Thank you very much. Okay. I think, I know it's Friday afternoon and everybody's eager to get out of here, but I think to really round this out, we need just a little bit more clarity on the CCIP program, because of the three components of the new HealthNet, that's the one that we get the most questions about in the Center for Health Policy, and I thought since we have such a expert panel here today, we might flesh that out a little bit. I'm sorry that Dr. Barrow had to leave, but George has generously offered to say a word about the CCIP program for us.
Thank you very much. I appreciate your indulgence for the second time on Friday afternoon. I'm not sure what Schomer had, or what Dr. Barrow had on the slides, but I'm going to go through them very quickly. And the ones that I do want to point out to you are the outcome-focused slides that give us some indication that we might be generally on the right path in the process. I think his first slides were on the APS, the company itself, so we can go through those. And then he's transitioning into smoking cessation and why folks are not doing well by taking care of their health themselves, and what goes to some of the issues associated with the implementation of the program. I can tell you historically that what we thought that would be logical is that we have about 20% of our population spending 80% of our dollars. Most of them are in several disease states that we found very quickly in the disease management program that they're not existent in isolation. So we did a risk stratification of all of our fee-for-service patients. We have about 550,000 patients that are in Medicaid fee-for-service, about 820,000 total. The rest of them are in our MCO programs. So in targeting those and trying to hone down on what that 20% looked like, we found that they had some commonality in several disease states, and those are probably not surprising to you at all. Asthma, diabetes, chronic obstructive pulmonary disease, chronic heart failure associated thereto, gastroesophageal reflux, and then interestingly enough, we added sickle cell anemia because of an interest in trying to give targeted coverage to those individuals. We did that at the first of last year. The opportunity then was to stratify them not only by the disease prevalence, but also by the relative severity of their disease within that targeting population, and it's an opt-out group. So we take all of those individuals that qualify, again about 140,000 folks across Missouri, started in the I-70 corridor, and then rolled that group of patients, said basically you're eligible for this new service, here's what it brings to the table to help you, will you work with us to try and make sure that your health is best prepared and guarded as it can be in between these programs and between the folks that are working with you. We have about a 95% retention rate within the population so far. We have now this month, at the end of September, about 58,000 of the 140,000 folks that are in fact in the program. Of the 140,000 folks, we believe that about 108 to 10,000 of those at the end of the day will remain in the CCIP program. Interestingly enough, if you get healthier, your interest in your health diminishes, at least for the time period that you're healthier. So we find that as we move down to the healthier populations, that we get less uptake, if you will, of the individual person in that extra program. APS is an ASO, an Administrative Services Organization that brings tools to the table to help us. And we're not doing the care for the practitioners. What we're trying to do is make it easier for the practitioners to provide the care. As Joe mentioned, just getting patients there for their appointments is often a challenge. both knowing, keeping the appointment, and physically getting to the site of the appointment, to make data and information available to the providers so we can know what the issue is, help the patient in between appointments, be attentive to the needs of that have been prescribed by the provider, and then supplementing the provider from one provider to another with electronic health data that may be meaningful to them. This is just a slide on the enrollment. You can see that we're projecting in December to be at 82,000. By the end of the fiscal year, we should be maxed out in June. The PM expenses by place of service gives you a before and after. It's a 6-month opportunity. It also represents an N of about 31,000. I would tell you that these are very preliminary. There's regression to the mean there. There's isolated issues associated with reporting, so that a grain, maybe even a boulder of salt in looking at these. But at least we're seeing things that we think are the right trends. A decrease in outpatient hospitals. We're seeing an actual marginal increase in pharmacy, and we believe, in fact, that will occur. If you have an asthmatic patient, we believe that the cost of pharmacy will increase if they take a more enhanced view of their own care and use their preventive medication. You can see that in inhaled corticosteroids, that relative utilization is up from where it was with that subset of patients, the N here being about 4,000. You can see from this that we're largely static in some of the other metrics that we'll be looking at associated with monitoring disease, specifically diabetes. The hemoglobin A1C, again, that's, I would say, a marginal increase. But this gives you an idea of the things we're going to be looking for, the successes if they increase. We should be at about 80% on the hemoglobin A1C. The lipid panel should be 75 or 80% at a minimum. Eye exam for a diabetic patient, I would hope that it would be up as high as 90%. And you can see the microalbumin, that's likely, if the rest of them come up, that will too, because it's traditionally part of the panel. The patients on cardiovascular medication, we've seen an increased adherence. These are the folks that were in first. We've got a relatively small N, comparatively speaking, about 3,800, but the right things are happening there as well. And again, would indicate to you that the pharmacy cost will go up. The members with COPD receiving a bronchodilator medication, again, same sort of thing happening. So we think the right things are starting to happen with that population, and that's the message. If they are, then sooner we get those sorts of messages to the patients, the more we can stabilize their disease and hopefully prevent the progression. Thank you.
That was great. Thank you, George. I think we'll open it up now for questions. I expect there'll be some. And so please raise your hand and they'll bring the microphone to you. Up here in the front.
Thank you. With improved and expanded chronic care for patients with multiple chronic conditions, there's going to be an expanded number of outliers, and that is those that live longer with severe disease who are quite ill and continue to increase utilization of services in health systems. What kind of incentives or disincentives are going to be in place to prevent cherry picking that might even occur within this system as we improve access and we improve services for those that will continue to live long but live ill?
It's a good question. I think there's nothing embedded in the system to date that would preclude that. I think the concept would be that at the end of the day, you're going to have a subset of patients that are going to be in the enhanced fee-for-service program, which is a state-operated program. I would suggest to you that's probably where you're going to see the aggregation of that particular subset of the population. So that will continue to be a state function, and therefore, as it falls back to a state role, it's likely not going to be subject to the cherry picking because it will, in fact, be a unilaterally supported state program.
I have a question about Insure Missouri. My clinical practice is at a federally qualified health center, and in recent years, being able to obtain hospital services or diagnostic services for the uninsured patients has become increasingly more difficult to arrange as a provider. It used to be much easier for me to schedule someone for a stress test or to schedule someone for an elective gallbladder removal if they were having recurrent problems. And I think my sense is that in part is due to everyone needing to sort of tighten their belts. And I have a question about Insure Missouri. I know that some of the funding is coming from the disproportionate share hospital dollars, and that it sounds like a great idea to shift that money into preventative care and to hopefully then have people be insured and have hospitals be reimbursed. I'm wondering, there still are going to be a lot of uninsured people. Even with this expansion, there are going to be lots of people that are still going to be showing up at hospitals and needing services. Since this is sort of a significant shift in dollars from hospitals into Insure Missouri, is there something in place to make sure that there are still significant and sufficient disproportionate share dollars there to allow hospitals to continue to provide some of the care for the uninsured that it seems has been increasingly more difficult for them to financially be able to afford?
Sure. I'd be happy to answer that. If this program is as successful as projected, we would think that by 2012 we'd be covering about 190,000 people. There are roughly 700,000 uninsured people right now. I think the diversion of dish payments would probably be comparable. Clearly it's something that, as hospitals, we're going to be watching very carefully. But about $189 million worth of dish payments would be redirected, as it were, when this is fully implemented. Our current pot of money that is available from the federal government for disproportionate share hospital payments is $517 million. So as long as that ratio and balance works out, things should be all right. We clearly don't want to spend all of our money for disproportionate share hospital payments to convert it to coverage, because there are a lot of people who are still going to be uninsured. Does that answer your question?
Right here.
Yeah, this question's for Joe. And I know that the Primary Care Association has been having some meetings with the Coalition of Community Mental Health Centers about coordinating services and coordinating care and looking at ways to link up and work together. Could you comment on where that's going?
Sure. The state in this past year's appropriation provided enough appropriations to cover 7 partnerships. They requested that the health centers and the mental health centers get together and collaborate and submit somewhat of a letter of intent prior to the actual application. And my understanding is that the mental health department received about 26 letters of intent. So I believe at the end of the day they're going to have more applications than they have funding to approve. So.
Other questions? Well, I have a question. Lots of people have asked me, and I've kind of wondered myself, as we move forward with the CCIP program, while we all recognize the importance and the value of having a medical home for patients with multiple comorbidities and chronic disease, what is the best way to incentivize patients who are used to going from doctor to doctor? How do you convince patients to invest in a medical home? Because there's going to be a significant number of people who really don't want to have that flexibility taken away from them.
Well, that's a good question. That's we certainly, part of the original 577 discussion was whether, in fact, certain incentives should be provided for patients to incentivize them. And as I alluded to, the patients that are the least ill will have the least incentive and will be more knee-jerk, I need care today, and the ER is the quickest, easiest opportunity. Why should I be involved in the process? And I think from a philosophical perspective, we just need to find those trip points for the individuals to try to make them more aware of how important it is for them to be participants in their own care. And I don't have an answer. If I did there, that would be an excellent opportunity for me to segue into a retired position and be a consultant and travel around. But I think that is the only thing to date that has appeared on the national scene to have some merit, is to provide incentives at the access point where the patient's least probable to want to work within the system.
Dr. Fleming?
To what degree will the presence of an electronic medical record be a minimum standard for practices to enter in? And that's part one. And part two of that question is, will there be added incentives for creating an EMR in those practices who do want to participate?
It's a great question, too. And to answer both of the questions, the first, currently in the chronic care improvement program, we're working with a program, a subset case management program, as well as our overall statewide tool. And we are paying additional dollars to incentivize the provider to enter data into that system. Longer term, we're looking at the opportunity to do an interoperable link with the electronic medical records that are available, and you know there are key providers within the area. We recognize and believe at the end of that opportunity there will still be a significant number of either solo practitioners or small practice practitioners that will not be able to have the resource available to do electronic medical records. To that end, we're trying to develop on the front end of our current tool a very basic electronic medical record that can be utilized both by us internally in a case management style, but also utilized within the small practices. Now, the other issue, of course, is can you only use it for your Medicaid patients? CMS has given us to understand that the basic development of the electronic medical record, if it resides at the state and is made and used predominantly for Medicaid patients, HealthNet patients, that we can make that available to all other patients for nominal cost associated, user cost associated with that. And we believe that we would be willing to incentivize that, A, to get the electronic data quicker, and B, to get the implementation of the technology transfer quicker. I think the other question was, will we ever require that you use that? I think that it will be a self-imposed requirement, because as we continue to add value to that tool, as your certifications are there, as your access to information is there, I think it will be something you will want, and I would much rather partner with you to try to build a product that is indispensable to you than make you use a product that is worthless and a part of your practice. So both of those hopefully will converge.
Question in the back?
Is there a difference between the terminology medical home and healthcare home? Are those two used simultaneously, or is there some distinction between the two of that terminology?
I think that the best way to answer that is the whole concept is a little ambiguous. So when I talk about a healthcare home, what I'm trying to impart by that is a multidisciplinary opportunity that may look different for different patients at different stages of disease and disease prevalence as well as severity of disease. Now, you would have some provider organizations that would be very targeted and have a physician-directed healthcare home being the only definition. We've tried to be much broader than that. So I think that's the distinguishing part. The outcomes from either are really largely the same.
Other questions? I have a question. What is it that Missouri's doing that is really innovative and different? That, you know, giving providers a little bit extra to participate, is that different than what other people are doing?
When we look around the country, I think the areas that we are most different right now are in the areas of integrating technology into the play, if you will. The pay for play, paying providers to incentivize them to enter data is probably not totally unique, but somewhat. if we're looking at electronic health records and the implementation of claims-based electronic health records, that we're probably one of a half a dozen that are at a real stage of implementation of that. So I think we're trying to leverage what, Missouri, we've always, in all of the polls for healthcare, are routinely in the 40-somethings. And we recognize that. But in this particular area, we were, and not way before my time, in the opportunity to do an integrated legacy-based system. We had all of our paid claims data already aggregated. So we had a little jump on everybody else rather than parsing it out in silos. We already, probably because we were behind, but by being behind we were ahead at that particular juncture, if you will. So we've tried to leverage that, and I think to that extent we're perhaps ahead of the pack a bit.
Other questions for our panelists? Deb?
I have a question about phase one of Insure Missouri. My understanding is that phase one of Insure Missouri will increase the coverage to parents of families that are under 100% of poverty level, which is a big jump from the current 22% of poverty level. And I immediately thought of several people I can now get medications for that haven't been able to get their asthma medicines and that sort of thing over the last couple of years. But then I read something that made me a little concerned, and I don't know if this has been clarified or not. And my understanding was that there's some consideration being given to it not just increasing to 100%, but to have it be defined more by excluding certain types of earned income, and which would mean that people that had money coming in from other sources like child care that might be over 22% of poverty level would not qualify. Has that been clarified, how that's going to be determined, what families will be able to qualify for that phase one?
I think they're in the process of determining that. I think what you're talking about is there are ways to use the Medicaid eligibility determination system to get where you want to be by excluding certain types of income. It's more a means of trying to get where you want to be rather than to try to exclude people. So basically, I think at the end of the day, people who have income at up to 100% of the federal poverty level should be able to get coverage. I think that's still being clarified in the standards that are being put together.
That's correct. And then with one of the segments of 577, in sheltered workshops, like that income could be excluded for that subset of the population, and therefore making the 100% drop down a little bit. So Daniel's correct. He actually I applaud him. That's the best overall view of Insure Missouri that I've ever seen. I actually started to understand things I didn't understand before, so appreciate that.
Wonderful. Well, I think we'll give our panelists a last round of applause. I think they've done a wonderful job. And I know you're all going to be heartbroken, but we're going to actually finish early today. And Chris and I and all the members of the Center for Health Policy, Gwen Rotterman and Stan Hudson and Larita Emanuel and Amy Sigmund and all of our wonderful graduate research assistants, we all just want to thank you and the Continuing Medical Education Office of the School of Medicine for all the hard work in putting this whole meeting together. And Rhonda and Nicole for all of their hard work. So let's give a round of applause for the organizers. Yeah, and your evaluation is in your packet, and particularly if you want continuing education credits, please fill that out and turn it in. And at the very end of it, there's a list of a few ideas about topics for our next year's Health Policy Summit. I think we've got childhood obesity on there and workforce and health literacy that we're all kind of steeped in right now and a couple other issues. But please think about that and write what you would like to hear about in more detail, what you'd like to talk about and think about, and we will take that under advisement. So.
There's a bin for their name badges.
Go ahead.
They want to recycle. Also on your way out, please drop off your evaluation forms. They're extremely important to us, so don't forget that. And then if you'd like to recycle your name badges, there will be a bin on the table where you registered so that we can not have to throw all those away and buy new ones next year, so save the environment a little bit. Otherwise, I think we're completed. So thank you so much. It's great to see you all here.